You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for professionals. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and an LLS volunteer. I want to thank all of you so much for joining us on this episode. Today, we're going to be discussing cutaneous T-cell lymphoma, including its pathophysiology, causes, risk factors, diagnostic tools, treatment strategies, and side effects, treatment resistance, and the need for a multidisciplinary team. And we're also going to look at disparities in care and emerging therapies. We're delighted to be joined by Dr. Jay Choi, who's an associate professor of dermatology and of biochemistry and molecular genetics at Northwestern University Feinberg School of Medicine. Jay, thanks for joining us.
Great, Ken. Thank you for having me.
I think the first question I want to ask is, how did you get involved in a career in T-cell lymphoma?
So, Ken, that's a really great question. So when I was a medical student, I did an MD PhD and a PhD in immunology. And when I graduated, I wasn't sure what I was going to do, but I was just mystified by some of these sages, these amazing faculty members at Yale, who had this remarkable ability to look at a patient and can instantaneously almost distinguish people with rashes like psoriasis and then from cancers like cutaneous T-cell lymphoma. And I just felt like it was something where if you had really thoughtful approaches and thinking about the pathophysiology and really making a patient-centric approach, you can make a huge difference in these patient lives. And then as I got into it, I was just really fascinated by the ability to deliver all these really interesting treatments for patients, really be able to help them with many different things, which include not only the cancer itself, but also intractable itch, quality of life. And what I also was really stunned by was just the tremendous deep relationships people with this disease form with their providers. And I just felt like all these really made for a wonderful career. And I've basically dedicated my entire life to either treating patients with this disease and or researching how to make new treatments for people who cannot be treated today.
So, yeah, thank you. I want to ask you about that because actually you and I were at Yale at about the same time. And I remember, hearing some of the stories of patients who had been undiagnosed for long periods of time. I'd love for you to share more about that because from what I understand, it's a common problem.
That's right, Ken. So I think actually most patients are not diagnosed. There's always a delay in the diagnosis. And the reason for that is actually because this is a very difficult thing to diagnose. It actually requires both a clinical eye as well as pathology to be in sync, to be able to integrate the information, to be able to make the diagnosis. So oftentimes, most patients that we see are seen in the community by people who are not experts in this field and don't really understand the classical clinical presentations of this disease. And therefore, they don't really fully understand how to integrate the pathology to be able to make the diagnosis early on. So most of our patients complain that they were diagnosed with something else like eczema or psoriasis for many years before they came into the clinic.
I want to drill down on that a little bit because I do find it really, really interesting. What are the similarities and the differences between, let's say, eczema or psoriasis and a T-cell lymphoma, both from the pathophysiology and then also clinically?
So I think if I start just big picture, it turns out that for many people, you have more T cells in the skin than you have in the blood. It's a tremendous number of cells that are probably designed to help protect you from skin infections like bacteria and viruses. And when you get a lymphoma, or psoriasis or eczema, it turns out these T cells are aberrantly activated. They make cytokines, cause inflammation. So oftentimes, to people without experience in this disease, they'll see the hallmarks of inflammation. They'll see inflammation being with edema, and they'll see inflammation with pinkness or redness, and they'll see inflammation within the skin, which can actually cause scale to develop, which is sort of the fine keratoderma that you can get in different areas. And eventually, what the real issue is that the fine-tuning of the differences are more subtle than that. And so it really requires someone to think about what are the classic features of eczema, what are the classic features of psoriasis, and what are the classic features of cutaneous T-cell lymphoma to distinguish the three.
All right. With that in mind, and as one of the experts in the field now, what helps you make that distinction?
So I can tell you that many of my colleagues use this point system, which is great. It's been data validated, but it's actually incredibly cumbersome because it makes it very difficult to put things together to give a point for pathology, a point for molecular studies. And as we all know, patients are on a spectrum. So what I generally do is use a broader heuristic. In all of dermatology, we always think of what does the rash look like? It's called morphology. And then we think about the distribution, which is where in the body it is. So I'll give you an example. Psoriasis tends to be a scaly plaque that's pink, almost salmon colored, and it tends to be on the extensor surfaces, like the outside of your elbows and knees. So if I were thinking about cutaneous T-cell lymphoma, and of course I'm talking mostly about mycosis fungoides, which is the most common subtype, actually it turns out most of these lesions are big, over 5 centimeters. They have edema, they have some scale, but one of the key aspects is that they are generally found in particular parts of the body where we traditionally wear 2 layers of clothing. And so for men, it's in the swim trunk area, and for women, it's often in the bikini area. And so I think this is a valuable tool that's really required to be able to make the diagnosis.
By the way, that is one of those clinical pearls that I think people will remember. So thank you.
Sure.
I have to say, as an oncologist, I treat and I think more about B-cell lymphoma. So what is the disorder in T-cell lymphoma? Where is the block? What's the underlying mechanism?
So I get asked by my patients all the time, why do I have this disease? And it turns out we think it's just really bad luck. And so it's like many other adult cancers where some of these cells have developed mutations as we age, and they occur in the wrong genes, which trigger a genetic program that allows for cancer to develop. What's interesting about this disease, and this is a lot of stuff done from our research as well as our colleagues, is we have found that at the core, these T-cell lymphomas are T cells. And so when they become transformed, they make a lot of cytokines, which is why you have these rashes, and they continue to proliferate often in what we call an antigen-dependent manner, meaning that they seem to require T-cell receptor signaling. So when I describe this to my colleagues in oncology is that I just always think the T-cell lymphoma is kind of like a supercharged T-cell. And so a lot of the mutations are actually in the genes that normally transduce signals for normal T cells. They're just hypercharged or supercharged to be able to have outsized effects, which cause this incredible inflammation and their ability to supersede negative homeostatic pathways that restrict their proliferation. So in essence, it's a genetic disorder like almost all cancers, including B-cell lymphomas, but the mutations occur in the T-cell signaling pathways that supercharge the T cells to be more inflammatory and more persistently proliferative than T cells.
What I'm hearing is perhaps 2 parts of this. Number one is the disorder of the T cells, make them sort of supercharged. And the second is the cytokines, which are causing the inflammation or causing the presentation.
That's right. So we think that the T cell develops mutations that actually supercharge these normal T cell behaviors. And almost all T cells have to both proliferate to be able to match the pathogens proliferating like bacteria and viruses, as well as to make cytokines designed for the removal of these different pathogens like bacteria and fungi. So when you supercharge these skin resident T cells, it turns out that you're making cytokines that are normally designed to do something else, but actually cause disease in these patients. So we think that patients with this disease not only have proliferative disorder, but overproduction of what are called Th2 cytokines. And this, we think, leads to the itch that is oftentimes plaguing the patients. And actually, a fair number of patients have really high eosinophils that are actually probably driven by high levels of IL-5 produced by the plastic T cell.
Been an oncologist a long time. It's not a common disease. So that's my disclaimer. What are the pathologic or physiologic differences between mycosis fungoides and cutaneous T-cell lymphoma? Or are they just manifestations of the same disorder?
No, that's a really great question. So it's very complicated, but it turns out is that, T cells are actually incredibly complicated because we need to have a very robust immune system to defend ourselves against a number of potential attackers. So we have CD4 cells, CD8 cells, gamma delta cells, et cetera. And as you can imagine, they could be in the skin, they could be Th1, Th2, Th17, have different polarized abilities to fight off different infections like fungi, bacteria, or viruses. So mycosis fungoides is the most common type of cutaneous T-cell lymphoma, but the cutaneous T-cell lymphoma is sort of an umbrella term that affects different lymphomas of skin homing CD8 T cells, skin homing gamma delta T cells, as well as skin homing other cell types that have different presentations. The vast majority of our patients have mycosis fungoides and Sézary syndrome, which is traditionally a CD4 T cell disorder.
I want to ask about the spectrum of disease that you see. I have had occasional patients over the years who've had very, very indolent disease, perhaps just one big plaque. And then there's obviously patients who are very, very ill with this. What are the determinants of that? And is there an evolution, or are those typically different syndromes?
So this is actually a little bit debated, but if you ask my opinion, I think that they're all related in the same spectrum. And the reason why we think it is because you have some patients with blood cancer called Sézary syndrome. You treat the blood compartment and then they'll develop skin disorders, traditionally of mycosis fungoides, and vice versa. We've seen this actually many times. I actually had one patient who was incredibly skeptical of the medical system and almost in her own way did a controlled experiment of someone who's not treated over years. And what we have found is that she had evolved from skin-limited disease and eventually progressed from the features of stage 1 to eventually stage 4 disease. So I actually am a firm believer that evolution is part of the process, and the delays in diagnosis lead to patients being diagnosed in stage 4 versus stage 1 disease.
Well,
What we know is that if patients are treated appropriately, stage 1 disease has incredible 5-year survival, close to 90 to 100%, depending on the stage. The survival curves are almost indistinguishable from people without cancer. And so what that tells us is that there are intrinsic mechanisms that prevent cancer progression in most patients. But also we have an incredible therapeutic index and be able to provide therapy specifically to the skin that we can't provide systemically to lymph nodes in like the gut or in the chest. And so I think it's both an opportunity where the disease has some intrinsic road stops that prevent it from progressing, but also we have a complete armamentarium not normally available for most people with blood cancers because it's in the skin.
I really never thought about that, the fact that you have a whole different array of treatments, including light therapy.
That's right.
I'd be interested in your experience in the diagnostic tools. So your visual inspection, there's the biopsy, imaging, molecular testing. Where are some of the problems there where all the results may not all be aligned with each other? What are some of the common issues?
Ken, that's a great question. So there's two things that are really critical here. So number one, the biopsy is not the same as for almost any other cancer type. Almost every biopsy that comes out that could be consistent with cutaneous T-cell lymphoma in the unexperienced eye or inexperienced eye could actually be a diagnosis of something else. That's number one.
Mm-hmm.
Number two, which is very confusing for most people, and we can talk about it, but actually people with stage 4 Sézary syndrome, their biopsies are actually less diagnostic because almost all of the signs and tools people use to make the diagnosis of mycosis fungoides is actually based on the hallmarks for early stage disease. And so ironically, late stage disease actually is a harder pathological dilemma. So the third part, which is absolutely critical, is most patients with skin diseases don't get blood work. But we have found if you are red or pink, called erythroderma, over large swaths of the body, 80% is the official diagnosis, but I often do it over 30, 40%. We order what's called flow cytometry, which can immediately help clue you into this diagnosis. But without it, it can be incredibly difficult to nail it down.
So you really do need all aspects and
That's right.
a very well-trained pathologist.
That's right.
I want to start talking about treatment some, but I can't help but ask, because in B-cell lymphoma, CAR T is where so many of the discussions are being held now. Is there any role for T cells in using CAR T in fighting cutaneous T-cell lymphoma?
Absolutely. So right now, at this point in time, there's multiple ways we can activate T cells against T-cell lymphoma. So number one, you can think about TLR agonists like imiquimod, which we think activate the innate immune system, which brings in T cells to fight the T-cell lymphoma. And again, this is sort of an agent that, if given systemically, could be highly toxic because they can be provided on the skin itself, can be very localized. So it plays a critical role in part of armamentarium for skin-limited disease. Number two, there's actually increasing usage of pembrolizumab or PD-1 for patients with cutaneous T-cell lymphoma. We have found some patients may progress on PD-1 immunotherapy. We have found sometimes they get a little bit of a flash. But it turns out that for the vast majority of patients, the PD-1 immunotherapy doesn't cause disease progression. And for a subset, it actually harnesses the innate, the anti-tumor immune system in the patient to be able to clear the tumors. And then lastly, there's CAR Ts being developed for T-cell lymphoma. And these are very interesting because like for B-cell lymphomas, they offer the possibility of durable cures. The only issue is that they try to target antigens that are selective for T-cell lymphomas, but they're often shared by normal T-cells. So I think the general spectrum right now is that they can be utilized, but then those patients will eventually have to go to bone marrow transplant to be able to have a full T-cell system after those CAR T therapies.
Well, obviously, there's a lot of therapies before then. Fill us in on sort of what you pull out of your tool belt at what stages or what presentations.
So what I normally start with is I often tell my patients, look, you have your diseases in areas of skin that are protected by two layers of clothing, just your underwear and your outerwear. And if you think about it, that tells you that the disease is actively trying to hide from the sun. And so I often use that as a strong rationale for patients with skin-limited disease to try phototherapy, which we traditionally do now with narrowband UVB. It's the most common phototherapy available in the US right now. And it is incredibly effective with patients with early stage disease. Some of the trials suggest 90-95% clearance with just phototherapy alone. I tell them you can get to about 24 treatments. That's sort of where you get to a good response dose where you can actually assess the responses. And it's incredibly effective at both treating the appearance of the disease, the pathology of the disease, as well as the itch. Now, being on the skin, we also have a huge armamentarium of topical and other therapies that are skin-directed. Corticosteroids are often used to help with itch and treating early stage lesions. We also have topical agents like these TLR7 agonists like imiquimod. We have topical nitrogen mustard or mechloroethamine now that's often given. And then we can also do radiation that is completely skin limited. It can be given in the traditional way or through electron beam and really have limited penetration beyond the skin. And so we have this huge armamentarium for skin limited disease. And then we also have systemic agents really for bloodborne disease or visceral disease. This includes mostly biologics. We often use things like bexarotene, which is an RXR agonist or interferon, pegylated interferon, as well as something called extracorporeal photopheresis or ECP for blood disease. And then we also have agents like antibodies or antibody drug conjugates like mogamulizumab, as well as brentuximab vedotin that can be used to really target cell surface markers of CTCL. And then lastly, we have targeted agents like romidepsin, which are HDAC inhibitors. And in severe cases, we do single agent chemotherapy like gemcitabine or doxorubicin.
So yeah, it is an incredible spectrum. Let me ask you more about, because again, I remember this from Yale, but extracorporeal photopheresis. What is the mechanism? And is that the same mechanism as actually phototherapy for the skin?
So it was, you'll be amazed, or maybe not. When Rick Edelson talked about it, he thought that it was actually going to be phototherapy of the blood, much like it is for the skin. But it turns out that he has found over the last few decades that it has incredible immunological effects that were unexpected. So what happens is you add sorlin to the blood and then shine the blood through a UV light through a glass plate. And that blood is returned to the patient during this procedure. The red blood cells are all sort of spun out, also given back so you don't suffer anemia. But the white blood cells, when they're exposed to the UV light, it turns out the T cells will apoptose. But it also turns out that dendritic cells will be made and or mature in the blood. And so I think the current thinking is it's kind of an immunotherapy where you're actually maybe almost vaccinating patients with this kind of apoptotic T cells with the dendritic cells into patients.
So how does phototherapy of the skin work?
It's a very good question. And actually with new techniques, we've learned a lot more about it. So if you do radiation therapy, it's very clear that you kill the tumor cells, that they're no longer there. And if you did next generation sequencing of the skin before and after radiation therapy, they seem to be gone. It turns out with phototherapy, we think it's less cytotoxic, but we think it changes the immune system in the skin. And just like normal T cells, cutaneous T cell lymphomas have to interact with antigen presenting cells and other cells to be activated. And we think that phototherapy actually just changes the immune milieu. So I often talk about it like if you're in a military campaign, you can think of it as sort of surrounding or assaulting like a castle and trying to prevent the food supply from being delivered to the cells.
By the way, I'm very much enjoying talking with you today. I think we all have our own analogies that we give patients. So I've learned some new ones today, and I appreciate it. I couldn't help but think, as you were talking about this array of treatments, you mentioned rituximab vedotin. So how does that work?
It targets CD30, which is a target that's shared by Hodgkin lymphoma,
Yes.
as well as cutaneous T-cell lymphomas. And so in a subset of cases, CD30 is highly upregulated and leads to the ability to be treated with rituximab.
And how about the HDAC inhibitors? What is the story there?
So it's often used as sort of one of the hallmarks by which epigenetic therapies or these therapies that actually target chromatin and DNA and transcription work in cancer. HDAC inhibitors have been approved for cutaneous T-cell lymphoma for a long time. It was one of the first of any kind of epigenetic therapy. And so there are two types. There's vorinostat and romidepsin. Vorinostat is a pill and is often thought to be a little bit weaker. Romidepsin's an infusion and is a little bit stronger. What we have found is people can have amazing responses to both therapies, but definitely romidepsin. It definitely helps the itch for some patients out of proportion to the disease. And what we have found is that in our cases, we can start people on the regular scheduled treatments, but if they have sustained responses, we can actually start to taper them over time, which enables them to actually continue to have the therapeutic benefits of romidepsin, but have fewer side effects related to the infusions.
It brings up a different topic, very important one, obviously, related to quality of life. What are the challenges that patients face who have CTCL? And then actually, I'd love to even transition to talk about what are some of the challenges that patients face on treatment.
That's a great question. So it's almost inevitable that almost all of our patients will have some form of itch. And it goes from mild itch to debilitating itch. And I think nowadays people appreciate itch, like pain, can be a very toxic stimulus in the skin. And our patients can complain of not being able to sleep. It can be extreme to be almost causing depression or even like suicidal ideations in very extreme cases. But it's just telling you is that this itch is unrelenting and is sort of often missed or underappreciated because people often have benign itch. And so because of this itch, it has to be dealt with straight on. And so we often use medications like gabapentin or pregabalin to actually address the itch directly while they're getting treatments. Most of the biologics we discuss, like phototherapy, ECP, mogamulizumab, they take time to work. And so addressing the itch is really critical to give them relief right away. The second thing that often happens is patients often have superinfections of bacteria. And so they often have Staph aureus or other bacteria that colonize the skin or cause infections. So we often address this as well. When it's really extreme, we give systemic oral antibiotics, but we can often take measures to really prevent the bacteria from being continuously growing in the skin. We can use topical antibiotics, but we often also recommend things like bleach baths, where you put a little bit of bleach in your water, and when you take a bath, it helps to sterilize the skin of some of the Staph aureus. So both of these issues have to be addressed head on and are often adjunct or really critical for the care for our patients.
What's next in terms of emerging therapies that you're working on and colleagues are working on?
So I think the big picture here is that it's a challenge that I think many people who work in hematology face, which is that across the all spectrum of cancer, blood cancers are a fraction, and cutaneous T cells are 4% of all non-Hodgkin lymphomas. And I think I was just telling you that there's many types of cutaneous T cell lymphomas. So the biggest challenge for us oftentimes is thinking about how do we develop the best therapeutics for this incredibly small number of patients? You know, people think there's about 6 patients for every million people in America. So you can imagine it's just a few thousand across the country every year. So what's been really driving this have been therapies that have been sort of designed for people with many different types of T-cell lymphomas. These include the CAR Ts that we discussed. There are also increasing number of bispecific engagers that are being thought of and tried to use, just like there are for B-cell lymphomas. But what I think is the next wave of therapies are kind of precision medicine, where we can really utilize our understanding of pathophysiology of disease and hopefully co-opt FDA-approved therapies for other diseases. And I think this is absolutely critical. You can imagine there's many ways to do this. The JAK-STAT signaling pathway is altered in many of these T-cell lymphomas using JAK inhibitors for myeloid neoplasms may be one place to start. And there's many, many examples of this where we're really trying to find an intersection where instead of doing these really expensive, underpowered campaigns in all patients with cutaneous T-cell lymphoma, we're doing targeted to molecularly similar disease similar, stage matched patients where we can really ask a very specific hypothesis and deliver a therapy that's most likely to work and that can be FDA approved for other therapies, enabling the cost for pharma to be much reduced, make it easier for patients to get. And I think that's the next revolution of cancer, both immunological therapies, definitive therapies, but also the sort of co-option of small molecules developed for other people.
It will be obviously very interesting to see how it plays out. You raised an interesting point about the practicality of it with small numbers. Jay, I wanted to ask you about the team approach. I mean, you trained at Yale, which is a great center for cutaneous T-cell lymphoma, and you're at a center now, which is a center of excellence as well. What would you recommend? What is ideal treatment in a community setting? Or is that the right way to do it?
No, absolutely requires multiple people to work together. As you know, we work side by side with hematologists, the dermatologists. We work side by side with the pathologists. And oftentimes, I think the best sort of regimen includes dermatopathologists, sometimes a hematopathologist, the dermatologist, and the hematologist all working together. And I can give you many different examples. For example, in late stage disease, oftentimes the therapies are being administered by the hematologist. But even in those cases, there are individual lesions that may require skin-directed therapy, may require consideration of itch or superinfection, where the dermatologist skills can be absolutely critical to be able to improve both patient of care as well as long-term outcomes. And then on the flip side, patients with early stage disease can often benefit by thinking like towards an endpoint. And so some of our patients are really thinking about allogeneic hematopoietic stem cell transplant because that's a definitive therapy that can potentially cure you of disease. And a lot of our patients want to meet the hematologist and/or stem cell transplant team to be able to think, what is the long-term vision that will enable me to be able to potentially have a cure? And so we often work together. We know the disease can change. We know the disease can go from blood to the skin to the blood. We know that there's oftentimes complementary systemic and skin-directed therapies. And because of the diagnostic dilemmas associated both with the treatments and the pathophysiology, you need incredibly invested pathologists who will patiently go over the biopsies and tell you if the disease is progressing, if it's regressing, or if it's related to side effect related to disease.
Yeah, along the lines of advances or things that are new, it sounds like there was a recent approval for a therapy in CTCL. Well, what was it? Tell us about it.
So it's called denileukin diftitox. And it's one of these things that is sort of like everything new is old again or everything old is new again. And this was a medication that is absolutely pivotal for some patients. It's sort of like an antibody-directed drug conjugate kind of thing where it really targets CD25. It's IL-2 diphtheria toxin fusion protein. And it was one of the therapies that has been around for many years, but for various reasons, it was taken off the market. And this recent approval allows for this drug, which we know has good efficacy, to now be, again, part of the armamentarium for hematologists around the country.
Terrific. Finally, I wanted to ask you about disparities, both in terms of diagnosis and treatment.
So, Ken, this is a very important question. Despite actually afflicting a very small number of patients relatively in the country, we know there's actually controvertible data that it seems like the prevalence of the disease is higher in patients who are African American and darker skin tones. It's for anecdotally, I just think about there's a number of young women with disease that have had really bad outcomes. And then we think that actually in general, the outcomes are poorer for patients who are African American. And so there's a clear need to understand why that is. You could imagine abstractly that these rashes may be difficult to detect earlier in patients who have darker skin. We all know that sometimes attitudes or approaches to medicine can be different based on your socioeconomic status and possibly also due to race. But I think that there's a firm belief in the community that there's something biologically different in these patients. And so the question will ultimately become is, should we treat them differently? Should we stage them differently? Should we be more aggressive up front? And this is something that will require really broad multi-institutional study because it's a small fraction of a small fraction, but it's absolutely need. I just think of a lot of our patients, really young women in the prime of their lives who are African American. Sometimes this disease can hit hard and progress much more quickly than some of their Caucasian counterparts.
Thank you for sharing that. So I think probably good for all of us to keep in mind who may not be treating the disease, but may be seeing it. Thank you. So again, this is Dr. Ken Miller. I have to say this has been such an interesting discussion about T cells, about T cell disease, about clinical dermatology and oncology. And I want to thank Dr. Jay Choi, who is an associate professor of dermatology and of biochemistry and molecular genetics at Northwestern University Feinberg School of Medicine. Jay, thanks for being with us.
Thank you so much for having me.
I also want to thank all of you for listening to this terrific episode and for a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, including a fact sheet about lymphoma. Please visit lls.org/CE. For any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. LLS also provides other resources for patients, survivors, and their families that can be found at lls.org/support. And I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. If you have suggestions for future episodes, we'd love to hear them. Please click the feedback button on this episode page. And finally, we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.